inviting me here to give this talk. I just wanted to get a sense of how many physicians are in the room. I know there's a lot of Masters of Global Health. Okay, so just a couple. I know this is the group from ID. Okay, if I say anything that is getting too medical, please raise your hand and I'll stop and I'll explain something in more detail. But I'm going to try to go through this at a level that everybody would be able to pick up on and really get the important points on. So as Colleen mentioned, I'm going to be presenting research that I started as a Global Health Fellow living and working in Botswana for 2 years. The study that I'm going to focus on today is looking at a specific group of children referred to as HIV-exposed uninfected. So these are kids who are born to HIV-infected moms, but who do not themselves acquire the virus. And this study is looking at the microbiology and outcomes of pneumonia in that specific group. I'm first going to give some background on what's known about the health outcomes of HIV-exposed uninfected infants, as well as pneumonia globally, and then move on to talking about the study, as well as our preliminary results, and really what are the implications of our findings for practice in Botswana and other high HIV endemic settings. So roughly 1.4 million infants are born to HIV-infected mothers in Africa each year, and of these, 1.1 million will not acquire HIV. These HIV-exposed uninfected infants have higher early childhood mortality, specifically during the first 2 years of life, than the children of HIV-negative mothers, who are referred to as HIV-unexposed. This figure shows data from 7 countries in sub-Saharan Africa. You can see that HIV-unexposed children are shown in dark gray. This is percent mortality, and the exposed uninfected children are shown in light gray. And in general, exposed uninfected children are roughly 2 to 4 times more likely to die before their 2nd birthday than the children of HIV-negative mothers. So why might these children be at risk for early childhood mortality? It's probably a combination of factors. Infant feeding practices certainly could play a role. So you can imagine that HIV-infected mothers may either just be less able to breastfeed because of illness, or they may choose not to breastfeed or to wean early in order to reduce the risk of HIV transmission to their infants. But that's clearly not the whole story. If you look back at those studies, a number of the studies that showed mortality differences between exposed uninfected and unexposed children were conducted in settings in which formula feeding is extremely rare. So even in the setting of almost exclusive breastfeeding, you see these differences. Maternal illness or death could also play a role. So again, mothers may just be physically less able to care for their infants because of illness. Exposed uninfected infants may be more likely to come into contact with infections such as tuberculosis. Socioeconomic factors certainly could play a role, particularly food insecurity in households of HIV-infected mothers as a risk factor for child undernutrition and all of the poor health outcomes that go along with that. And then finally, there are a number of well-described immune abnormalities that result from in-utero exposure to HIV itself, as well as to antiretroviral medications. And as you can see on this figure, these immune abnormalities are really, it's a broad range of abnormalities of both the innate immune system as well as the adaptive immune system. So the immune system that responds to pathogens with memory. And included in this are lower antibody levels to a number of common childhood pathogens. Exposed uninfected infants also have lower CD4 and CD8 T lymphocyte counts, sort of going along with what you would expect with HIV infection as well. And I'm going to show you how immunosuppressed these kids actually are. But importantly, these immune abnormalities are present at the time of birth, and then as the children get older, they decline. So the differences between exposed uninfected and unexposed children, they remain detectable throughout the first 2 years of life, but really they become less prominent as the child gets older. I think it's helpful to think of exposed uninfected infants and their immune functioning as being on the spectrum between HIV-infected children and unexposed children. And so this is one immune measure. This is CD4 T lymphocyte percentage at birth. And this is comparing HIV-infected children to exposed, uninfected, and unexposed children. Infected in this situation means that this is an infant who is infected with HIV in utero. So at the time of birth, this child is already testing positive for HIV. Exposed uninfected, again, was exposed to HIV in utero, so born to an HIV-infected mother, but tested negative for HIV at the time of birth. And then unexposed, again, those are the children of HIV-negative mothers. And you can see relative to unexposed children, exposed uninfected children have lower overall CD4 cell percentages, but it's a relatively mild immunodeficiency compared to what's seen in children who are infected with HIV in utero. If you look at a number of the other immune measures, you see similar trends. Not surprisingly, there are data to suggest that these exposed uninfected infants are at higher risk of infections, and in particular, respiratory infections. So they have a higher incidence of pneumonia. They have a higher risk in mortality of disease caused by Streptococcus pneumoniae, which is sort of the major childhood respiratory pathogen. And they have a higher risk of serious infections caused by encapsulated bacteria, again, most of which are respiratory pathogens. Pneumonia is an important cause of death in children in general, regardless of HIV exposure status. Globally, it accounts for roughly 1 million child deaths each year, or 18% of under 5 child mortality. And it's a disease that really affects children, the world's poorest children, so children in low and middle income countries. So this figure shows on the left causes of under 5 mortality in Ethiopia as a representative low income country, and Germany as a representative high-income country. You can see in Ethiopia, more than 1 out of every 5 child deaths is from pneumonia, whereas in Germany that accounts for only about 2% of the under 5 mortality. And indeed, if you look at pneumonia deaths, more than 99% of them are occurring in low and middle-income countries. One contributor to the higher mortality from pneumonia in these countries is HIV infection. So we know that HIV-infected infants have higher mortality from pneumonia than unexposed children. And we know that this is partly related to their risk of infection from opportunistic pathogens, Pneumocystis jirovecii, as well as cytomegalovirus, another opportunistic infection that can cause lower respiratory infection in HIV-infected children. And so recognizing these two facts, the World Health Organization in 2010 released specific treatment guidelines for HIV-infected children that include initial treatment for PCP pneumonia in children who are presenting with severe pneumonia, HIV-infected children with severe pneumonia. Far less is known about exposed uninfected children. There was a small study that was done in South Africa that suggested that these children also tend to have worse outcomes from pneumonia than unexposed children. And then there have been a number of case series describing pneumocystis pneumonia in exposed uninfected infants in both developing and developed country settings, so including here in the United States. And so this is providing some clinical evidence of immunodeficiency to go along with what's been shown in the lab as far as the immune defects among these children. But really, there hasn't been a study that's systematically looked at this group and tried to define the causes and outcomes of pneumonia. And because of that, there aren't any specific treatment recommendations for pneumonia in this group. They're essentially, once they're confirmed to be HIV negative, they're essentially viewed as being similar to the children of HIV negative mothers. So the objectives of our study was first to determine whether pneumonia outcomes differ between HIV-exposed uninfected and unexposed infants. We next sought to describe the causative organisms of pneumonia in Botswana. And then lastly, putting these first two objectives together to try to identify either an immunological or a microbiological basis for treatment failures in HIV-exposed uninfected infants with pneumonia. I think as many of you know, Botswana is a landlocked country in southern Africa. It's located just north of South Africa. It was a British protectorate up until gaining independence in 1966, and then very good timing for discovering diamonds several years later, and has become the world's largest producer of diamonds. And because of that, the gross domestic product is almost $19,000, which places Botswana as classified as a middle-income country. Of course, the revenue that was generated from diamonds hasn't been distributed equally in Botswana, so there's a lot of income inequality. There's still very high rates of severe poverty throughout the country. The climate is semi-arid. About 70% of Botswana is covered by the Kalahari Desert. And this is sort of what most of the land in Botswana looks like. Botswana is, of course, also one of the countries most affected by HIV. The prevalence of HIV among pregnant women has been hovering around 33% for the past 5 or 6 years. But really one of Botswana's major successes in fighting HIV/AIDS has been its program to prevent mother-to-child transmission. So over the past 15 years, that program has reduced the vertical transmission rate from roughly 20% to around 2.4% with this most recent data. And that's the lowest in Africa. And so currently the situation in Botswana is that you have a very high prevalence of HIV among pregnant women and a low rate of transmission to their infants. And as a result, roughly 1 out of every 3 infants born in the country today are exposed uninfected. And so identifying any special health needs of those kids is really of enormous public health importance for Botswana going forward. The Botswana government has really done a remarkable job of investing in healthcare, and in particular in responding to the HIV epidemic. Botswana provides universal health care to all of its citizens, and that includes lifelong antiretroviral therapy, and for better or for worse, free formula for HIV-infected mothers that are deemed to be able to safely and sustainably breastfeed. There has been a major emphasis in Botswana on preventive healthcare, and so there's an extensive network of clinics in many of the major cities, as well as health posts that have been established throughout the villages and the more rural areas. So as a result, there's very good coverage of childhood vaccinations. Haemophilus influenza type B vaccine, there is greater than 90% coverage among children for that vaccine. And then Botswana was also one of the first countries to introduce the 13-valent pneumococcal conjugate vaccine. It's again a vaccine against Streptococcus pneumoniae, and coverage rates right now are somewhere in the range of 70 to 80% for children less than 5 years of age. The study I'm going to present is being conducted in Gaborone, which is the capital and largest city of Botswana. It's a city of roughly 200,000 people that's located just north of the border with South Africa. And you can see from the image in the upper right that there are relatively modern areas within this city. Most of the children who would be included in our study might come from a typical residence in a poor area of the city. That's shown in the lower left here. And then this is, we also enroll children who come from rural areas surrounding the city. So this is sort of what a typical village setting in one of those areas might look like. The hospital itself is a referral hospital. It has a relatively large pediatric ward of about 50 beds that's supervised by pediatric specialists and really run by pediatric residents and medical officers. Supplemental oxygen, as well as bubble CPAP, that's continuous positive airway pressure, a way of giving an infant a little bit more respiratory support than just typical oxygen. Those are routinely available on the ward. And then there's also limited access to mechanical ventilation in hospitals, small intensive care unit, although primarily for infants that are above 5 kilograms and large enough for that intensive care unit's ventilators. So now moving on to our actual study. So we've been conducting a prospective cohort study of children with community-acquired pneumonia. We started enrollment for this study in April of 2012, and the data I'm presenting today are for enrollment through July of 2015. And so what we do is we recruit children within 6 hours of their arrival to the hospital based on their triage time in the emergency department. We gather data at enrollment, and then we follow these kids throughout their hospitalization until hospital discharge or death. The primary outcome of the study, our way of sort of considering a child a treatment success or a treatment failure, is assessed at 48 hours. It's a composite outcome variable that we call treatment failure. And importantly, this is an observational study, so any antibiotic and clinical care decisions are at the discretion of the child's medical team. This shows our data collection timeline in a little bit more detail. So again, within 6 hours, we recruit these 6 hours of their arrival to the hospital, we recruit these children. We obtain written informed consent from one of their legal guardians, and then we gather enrollment data from a number of sources. We conduct a brief interview with the caregiver to gather information about the household environment. We review both infant and maternal medical records, and that includes for all results of HIV testing. We perform a brief physical exam on the infant to get a sense of the severity of the child's illness, as well as to look for other comorbidities like malnutrition. And then we collect a number of specimens for microbiological testing, specifically a nasopharyngeal swab, a whole blood specimen, and a serum specimen. Children are typically admitted to the hospital. Our primary outcome is assessed at 48 hours. And again, we follow these kids until they go home or until death. Children are eligible if they're 1 to 23 months of age. And so we're focusing on these particularly young children, really because, again, that's when most of the differences that have been seen between exposed, uninfected, and unexposed children have been observed. So we're focusing just on the first 2 years of life. And then we use a clinical case definition for pneumonia that was developed by the World Health Organization. So children have cough or difficult breathing and lower chest wall indrawing. We exclude children who have chronic medical conditions that predispose to pneumonia. That's other than HIV infection and HIV exposure. Children who have been recently hospitalized, and then children who have a known diagnosis of asthma or whose respiratory distress resolves with nebulizer treatments. This is just, I wanted to point out that this definition was really, although this study is being conducted at a referral hospital, this definition was really designed for first-level healthcare workers who are seeing children in settings with limited diagnostic capabilities. And so it doesn't incorporate auscultation, doesn't incorporate chest x-ray findings, and it really doesn't make any attempt to differentiate children who have true radiographic pneumonia from other respiratory conditions like bronchiolitis, and even some non-respiratory conditions that can also present with respiratory distress. And so it's felt that it's very sensitive in that most children who have pneumonia would be picked up with this definition, but it's relatively non-specific. We know by using this definition we're going to be including children with bronchiolitis, we're going to be including children with these other medical conditions. And the reason that we chose this is really for our findings to be generalizable. We had to use a definition that could be easily applied by medical staff even without advanced training. Most children who have pneumonia in the world don't see a physician, don't ever get an x-ray, and so really for our results to be available to those groups, we had to choose this definition. We determine a child's HIV exposure status, again, based on either written or electronic documentation of HIV test results in the mother and the infant. So we classify a child as being HIV unexposed if the mother tested negative for HIV during pregnancy, at delivery, or at the time of enrollment. We classify a child as being HIV exposed, uninfected, if the mother tested positive for HIV before or at the time of delivery, and the infant tests negative for HIV at least 6 weeks of age. That's if the child was exclusively formula fed and would not have been exposed through breast milk. If the child was breastfed, we consider a child to be uninfected if they test negative for HIV at least 6 weeks after that last exposure, or a child tests negative for HIV at the time of enrollment. HIV-infected children are identified based on positive testing for HIV by PCR if they're less than 18 months of age, or based on a typical antibody-based method like a rapid HIV test or an ELISA-based test that might be done in children who are above 18 months of age. Our primary outcome is treatment failure at 48 hours, and it's defined as any of the following. So persistent lower chest wall indrawing, the appearance of new WHO-defined danger signs. So these are signs that the child's pneumonia is actually worsening. An oxygen saturation of less than 80% on room air, requirement for continuous positive airway pressure or mechanical ventilation, and obviously death as well. And importantly, this is assessed by a study physician or nurse who is completely blinded to the child's enrollment data, and that includes all data of HIV exposure status. So all this individual knows is the child's name, the child's cubicle, and the time that the assessment needs to be performed. And that's, of course, to prevent any sort of preconceptions that the study team might have as to how these children would be expected to do. Children are not infrequently discharged before this 48-hour assessment, and so we consider those children to be treatment responders, but then we contact their caregivers by phone to verify that they haven't required any further medical care. We've been about 95% successful in doing that. The nasopharyngeal swab specimens are being sent to our collaborators at McMaster University in Canada, and those specimens are being used to test for common respiratory viruses, which you can see here on this list, using PCR. Any specimens that test negative for this initial group of respiratory viruses are then tested for using an extended respiratory virus panel that detects an additional 11 viruses. And that's a panel that's commercially available from Luminex. And then our whole blood specimens are being sent to the University of Utah, where we're also using PCR to detect bacterial pathogens. These are the most frequent pneumonia pathogens, bacterial pneumonia pathogens in children. We don't yet have results on that, so I'm not going to be presenting anything more on that today. For our statistical analyses, we use Cox proportional hazards model to estimate risk ratios for treatment failure and in-hospital mortality according to the child's HIV exposure status. And then we use negative binomial regression to estimate mean differences in days of respiratory support, as well as mean length of stay, again based on HIV exposure status. And all of these models included age and proximity to healthcare services as potential confounders. Those were identified based on a literature review, as well as constructing a causal diagram. I noticed a few frowns when I said negative binomial regression. So that is a method that you can use if your distribution is skewed, which is what we see in length of stay as well as in days of respiratory support. So that's why we use that instead of a standard linear regression model. This shows our enrollment numbers to date. We've screened 725 children. We've had 337 children who were ineligible for one or more reasons. We've had 20 legal guardians that declined consent, and we've enrolled the remaining 368 children. I'm going to present data for 357 of these children today, excluding 11 children who were second-time enrollments and 4 children for whom we weren't able to identify or determine their HIV exposure status. So of these 357 children, we have 225 unexposed children, we have 102 exposed uninfected children. It's important to note that more than 80% of those children were confirmed to be HIV negative at the time of the enrollment. Then we have 30 HIV-infected children, most of whom were new diagnoses and were not on antiretroviral therapy at the time of enrollment. This shows baseline characteristics of our study population. So HIV unexposed children are shown here in this column on the left, and comparisons with exposed, uninfected, and infected children that are significant are highlighted in the middle columns and on the right. And you can see comparing exposed uninfected to unexposed children, exposed uninfected children were significantly younger than unexposed children and were less likely to be currently breastfeeding. But importantly, there was no difference in the rate of severe malnutrition, measures of socioeconomic status. So I'm just showing 3 here, but we really looked at a number of other measures and didn't find any significant differences in these households, as well as measures of disease severity on presentation. We look now at HIV-infected children. They also were younger than unexposed children, more likely to be severely malnourished, as you might expect. Again, no significant differences in socioeconomic status. But these children had a lower median hemoglobin, again, going along with chronic illness, as well as a lower median oxygen saturation, a sign of more severe pneumonia on presentation. Looking now at our outcomes, so how did these children actually do? So we had 36% of the study population, 128 infants who failed treatment at 48 hours. And when you look at it by HIV exposure status, 28% of unexposed children failed treatment, 46% of exposed uninfected children failed treatment, and a full 63% of our infected group failed treatment. And in our analyses adjusting for age and proximity to healthcare services, in utero exposure to HIV increased the risk of treatment failure by roughly 50%, whereas HIV infection nearly doubled that risk. We see similar findings when we look at our other outcomes. HIV-exposed uninfected infants required significantly more days of respiratory support, supplemental oxygen, CPAP, or mechanical ventilation. And they also had a length of stay that was roughly 1 day longer than children in the unexposed group. You can see that infected children, however, had substantially longer length of stay, as well as required more respiratory days of respiratory support than really either of the other two groups. And then finally, looking at the most important outcome, of course, in-hospital mortality. We had 24 children who died, that's 7% of the study population, 2.6% of our unexposed group, 12.8% of our exposed uninfected group, and 16.7% of our infected group. And again, in our analyses adjusting for age and proximity to healthcare services, in utero exposure to HIV increased the risk of in-hospital death more than 4-fold, whereas HIV infection was associated with a more than 5.5-fold increased risk of death. This figure shows the importance of age in modifying that relationship between HIV exposure status and our outcomes. So I'm just going to show data for in-hospital mortality because it's where you see the most significant modification by age, but you see similar trends when you look at our other outcomes. So this figure is showing unexposed children on the left, exposed uninfected in the middle, and infected children on the right. Within these groups, the black bars represent children of all ages. The light gray bars represent children less than 6 months of age, and the dark gray bars represent children older than 6 months of age. Now, comparing just first these two groups, you can see if you look at the older children, children older than 6 months, there really were no significant differences in the in-hospital mortality rate between unexposed and exposed uninfected children. But if you look at the children who were less than 6 months, exposed uninfected children were roughly 10 times more likely to die than unexposed children within that age range. And so it's really the effect of in utero exposure to HIV seems to be, at least for mortality and for pneumonia outcomes, seems to be limited to that first 6 months of life. As you might expect, HIV-infected children had higher mortality regardless of age. I mentioned that we didn't assign these children to any specific antibiotic treatment, but we did record those data. The most common antibiotic regimen was ampicillin and gentamicin, which is consistent with current World Health Organization pneumonia treatment guidelines. And if we look at how otherwise children were treated by HIV exposure status, so HIV unexposed and exposed uninfected children were roughly the same likelihood to receive antibiotic therapy. So again, children who didn't receive antibiotic therapy, many of those children had bronchiolitis or were assessed as having conditions other than pneumonia. HIV-infected children were universally treated with antibiotics. And then if we look at other specific treatments that these children received, exposed uninfected and infected children were significantly more likely to receive third-generation cephalosporin, which is an antibiotic that is typically within WHO treatment recommendations reserved for second-line therapy. So for children who have failed ampicillin and gentamicin, often you would then switch to a third-generation cephalosporin later on in the treatment course. We found that these children were more likely to receive this therapy initially, presumably because they were perceived to be at higher risk of having a poor outcome. And then, again, looking at pneumocystis, this opportunistic pathogen that we know HIV-infected infants can get, and there are some data that exposed uninfected children can get. Not surprisingly, these two groups were also more likely to be treated upfront initially for PCP. Looking a little bit more at this question of PCP, so we're not able to obtain lower respiratory tract specimens in Botswana. We really don't have the intensive care services to support these children were they to worsen while we were obtaining those specimens. But we have developed a clinical case definition that incorporates the lactate dehydrogenase, which is a screening tool that's used really in most resource-limited settings for PCP. It's been shown to have reasonable sensitivity and specificity for that diagnosis. So we consider children to have probable PCP if they are aged 2 to 23 months, severely hypoxic, so an oxygen saturation less than 85%, and they have an LDH that's above 750. That's very high, so that's more than 3 times the upper limit of normal for a child of this age, based on data that are available from African infants with pneumonia. We'd expect that that should have a specificity for a diagnosis of PCP above 90%. Now, looking at our data, we had 69 children who had an LDH sent because the clinical team was suspecting PCP. When you look at the percentage of children who met our criteria for probable PCP, 7 of the 19 HIV-infected children met criteria. 5 of the 38 exposed uninfected children met these criteria, and we had 1 unexposed child who met those criteria. Interestingly, that was a child who had severe edematous malnutrition, which again is associated with immunosuppression and which has certainly been associated with pneumocystis pneumonia. All 5 of these exposed uninfected children who were identified as having probable PCP were in that age range of being less than 6 months, and unfortunately all of them died. So I think what these data suggest are that PCP is a relatively infrequent cause of pneumonia overall in exposed uninfected children. Certainly if you look at the number of children with infected children who seem to have PCP compared to the exposed uninfected group, it's a much smaller proportion of the pie. But it seems that PCP may be contributing to the excess mortality that we're seeing in those very young exposed uninfected infants. I'm next going to present some of the microbiological data, really the respiratory virus data. But I first wanted to show the distribution of pneumonia cases that we see based on month of year and season in Botswana. So it's very similar to what we see here in the US, where in early winter months, as temperatures are cooling, we see our largest peak of pneumonia cases. And in the southern hemisphere, that corresponds to March, from March to June. This now looking at our actual detection of respiratory viruses from cases with pneumonia. Again, pneumonia cases are shown in this black line up here, and then these are the specific respiratory viruses down here, these lower bars. And it jumps out at you, but you can see that the peak in pneumonia cases that occurs in early winter corresponds very closely with this blue line, which is respiratory syncytial virus, or RSV, sort of suggesting that this really is one of the dominant viral pathogens in children in Botswana, and that a lot of the seasonality of pneumonia relates to RSV activity that's going on in Botswana. So now looking at our respiratory virus results by HIV exposure status. So unexposed children up here on the left, exposed uninfected children on the upper right, and then infected children here on the bottom of the screen. And again, just first comparing these two groups, unexposed to exposed uninfected, I think you can appreciate that the distribution of respiratory viruses in these kids looks very similar. Really, the only difference that was approaching statistical significance was this light gray bar, which corresponds to children who had negative testing for respiratory viruses. So despite everything we did, we weren't able to detect a respiratory virus. The most common viruses that we saw in both these groups were rhinoenteroviruses. Those are shown in green. RSV, respiratory syncytial virus, which is shown in blue. Human metapneumovirus. These are parainfluenza viruses shown in orange. And then flu influenza viruses are shown in yellow. So really the only significant, or only difference that was approaching statistical significance in these kids was that they were more likely to have negative testing for respiratory viruses. On the other hand, you can see what it looks like in HIV-infected children. Their distribution of viruses is very different from either of the other two groups. Roughly 2/3 of these children had negative testing for respiratory viruses. And when you actually look at this category of children, many of those children who met criteria for probable PCP fell into this group. And so it's likely that this piece of the pie is being made up by that opportunistic pathogen that's not detected by the molecular testing that we're doing. It's also a number of the children that I pointed out, the exposed uninfected children. A number of those children also had negative viral testing. So PCP may also be accounting for some of that increase in this piece of the pie in exposed uninfected children. Determining the significance of respiratory virus detection in children with pneumonia is difficult because we know that even in children who have mild or no respiratory symptoms, you can often detect respiratory viruses using PCR. And so in order to get a better sense of which viruses in Botswana were really strongly associated with pneumonia, we enrolled in parallel a group of healthy controls at 18 public clinics in the Gaborone area. And so these children essentially met the same criteria as our cases with pneumonia, but they didn't have WHO criteria pneumonia. So that was the only difference between those two groups. We matched them based on enrollment date and primary care clinic. So our nurse, if we had a pneumonia case from Lesserane Clinic who came into the hospital, our nurse within 2 weeks would go specifically to Lesserane Clinic to enroll a similarly aged control child who did not have pneumonia. And from all of these children, we collected a nasopharyngeal swab specimen and a whole blood specimen. This shows the distribution of respiratory viruses in pneumonia cases on the left, compared with our matched controls on the right. You can see that we detect viruses from pneumonia cases in more than 3/4 of these cases, whereas 34% of our controls we were able to detect a respiratory virus. Again, the most frequent viruses, again, are rhinoenteroviruses, RSV, and down the list as before. And when we look to see which viruses are specifically associated with pneumonia status, there's really 3 major viruses that fall out. So RSV, as you can see shown in blue, strongly associated with being a pneumonia case. Human metapneumovirus, we actually had no controls from which we detected human metapneumovirus. And parainfluenza viruses were also strongly associated with pneumonia. And so what this suggests is in Botswana, in this population, it doesn't tell you that this is the only organism that's causing a child's pneumonia, but it suggests more strongly that it's likely to be playing a role if you find it from a child with a lower respiratory illness. I mentioned that we're sending our specimens to our collaborators in Canada and in the United States, and that really was based on what was available in Botswana at the time that the study started. We have really been able to, through this study, develop local capacity to improve molecular testing that's available at the National Health Lab in Gaborone. So our project is supporting a master's student, shown here in this photo, and she is doing her thesis project specifically on the role of cytomegalovirus in HIV-infected and exposed uninfected infants within our pneumonia cohort. So she's used specimens from our pneumonia study to develop and validate a CMV PCR that can be done at the National Health Lab there in Botswana. And that really has utility both for diagnosis of CMV-associated pneumonia in young infants, but even more broadly for other CMV conditions like congenital CMV. And so we're hoping that that's really going to start to build up the molecular testing program in Botswana. She also, using study specimens, has been able to introduce the first respiratory virus testing that's been done in the public sector in Botswana. So that was started in June 2015. Right now we're just targeting the major respiratory pathogens in children, RSV, the major respiratory pathogens in children for which we know that we can, detection can actually influence how you might manage a child. So RSV is in that category, and we're also detecting influenza viruses as well. And so that testing has been available really to the pediatric ward at the hospital since June of 2015, and then it is also available going forward in the event for surveillance in the event that there was to be a viral pandemic as occurred with H1N1 flu a few years back. Our study has a number of limitations. I mentioned we are not obtaining lower respiratory tract specimens that would really be needed in order to confirm our diagnosis of PCP. We have not yet looked at data from bacterial pathogens. We didn't standardize antibiotic treatment, but again, we don't see any significant differences and how these children are being treated, that would account for the differences in outcomes that we're seeing. And then lastly, we're very interested in looking at the role of infant feeding practices here. And unfortunately, we've enrolled to date a relatively small number of exposed uninfected children who were breastfeeding at the time of enrollment. And so the study is going to be continuing into mid-2016. And really our hope is that as more HIV-infected women in Botswana start to breastfeed, we'll be able to get a better sense of what role infant feeding practices really are playing in mediating the poor outcomes of these children. So the implications of this study are that exposed uninfected infants with pneumonia have worse short-term outcomes and higher in-hospital mortality than unexposed infants, but only during the first 6 months of life. And again, we have some preliminary data that suggests that PCP may be accounting for at least the difference in mortality that we're seeing between exposed uninfected and unexposed children. And again, in children in Botswana with pneumonia, detection of RSV, human metapneumovirus, and parainfluenza strongly suggests causation for pneumonia in Botswana. I'd like to thank Colleen, who's my mentor here at Duke. This study is being conducted through the Botswana UPenn partnership. I also have ongoing mentorship from a number of faculty at Children's Hospital of Philadelphia. Obviously have the support of the Department of Pediatrics at Princess Marina. I think Colleen already covered the funding sources. And that's really it. Take any questions? Stuart.
Among those children who are of HIV-infected mothers who are breastfed, are they maintained on antiretroviral therapy while they're on breastfeeding?
So that's in shift right now in Botswana. So Botswana is currently in the process of moving towards doing Plan B, where women are started on antiretroviral therapy during pregnancy and then are essentially continued on it for life. As of right now, if the mother is not on antiretroviral therapy, what's standardly done is that those babies are given once daily nevirapine as a prophylactic throughout the period of breastfeeding. I think that's going to go away relatively quickly as Botswana really moves towards universal treatment.
Given the current status, how much transmission is there postnatally?
From breastfeeding?
Yeah.
A suspicion is relatively little, at least in where this study is being conducted in Gaborone. I mean, certainly, in general, the proportion of adults who are on antiretroviral therapy is very high in Botswana in general, so many of these mothers are on antiretroviral therapy anyway. And again, based on our cohort, roughly 90% of those kids were not breastfeeding. It's a little deceiving because that's at the time that they were enrolled, but even if we look to see what proportion of exposed uninfected children were breastfed at any point, it's maybe somewhere between 10 to 20%. So I think right now the rate of formula feeding is very high, and the rate of exclusive of antiretroviral coverage in the mothers is very high as well. Do you have a question?
I just wanted to know if there was like an average time that these infants come into the hospital, the uninfected exposed, with pneumonia or pneumonia-like symptoms. It's like,
You're saying season or time of day?
well, I guess I'm thinking like from time of birth. Is there any correlation? Like,
Yeah, so they clearly present earlier. When you look at the category of children that are presenting to the hospital and are meeting our pneumonia criteria, their average age was roughly 5 months, whereas the unexposed group was much older. The infected group was even a little bit younger than that. And so, yeah, that begs the question of why are they presenting earlier? Is it a difference in the microbiology? Is it that they have different organisms like PCP? Or is it that this is just a critical period of time when their immune functioning is particularly poor? I don't think we know the answers to that.
Really nice presentation. So you basically hit on the breastfeeding issue, if that's playing a role, but did you look at stratifying and see those who seemed like they had been breastfed versus those who had not? Did that change, or were the numbers just too small?
Yeah, so if we just sort of separate them out, the numbers in the exposed uninfected group are so small. You know, we only have about 15 unexposed children who were breastfed at the time of enrollment. We have looked at both the unexposed group and the infected group to see whether or not breastfeeding is actually affecting outcomes in those groups. We actually see no differences based on treatment failure, in-hospital mortality. So at least for those two groups, it doesn't seem like current breastfeeding is a huge factor as far as how those kids do. Could exposed uninfected children be different? Certainly, it could be sort of multiple different things going on in those kids, and breastfeeding maybe, formula feeding may be one more thing that tips them over the edge and makes them do particularly poorly. But at least based on those other groups, it doesn't seem to be a huge factor.
And in general, you mentioned that you can get formula for free. So if you have no HIV risk factors, is it traditional that women do breastfeed?
Yeah,
okay,
I think more than 99% of the unexposed group is breastfed.
And then my other question, you mentioned a lot had HIV test on admission. Do you know of the HIV-exposed uninfected, how many of them had sort of a confirmatory? Like, were they all tested again on admission, or could it be that you thought they weren't infected, but actually they were?
So 82 out of those 102 tested negative at the time of enrollment. Many of those children, it was a retest, so they had their 6-week PCR that was negative, but then they came in with a severe pneumonia, and it was confirming that this child was in fact negative. A good proportion of them were kids who hadn't yet had any HIV testing, and that was their first HIV test. These tests are some proportion of children. It is standard to repeat any positives. We don't repeat negatives. Again, usually the sensitivity is very high, so it's not that we would have repeated it routinely twice during the enrollment.
And do you know of the 5 who died, how many had a repeat?
So every exposed uninfected child who died was tested at the time of enrollment.
And was negative?
Yeah.
Okay, so
the children who weren't tested were actually the kids who had relatively mild illness and were discharged essentially before the team repeated the testing. We, about a year ago, started routinely obtaining dried blood spots from all of these children, and so we've started testing those children as well. We haven't had any unexpected positives, but yeah, it's not that it's the sickest kids that are dying that aren't getting tested.
And you had a significant amount who were newly diagnosed, so I think that's also quite impressive.
Yeah.
I have
Yeah.
one. I know that you mentioned that you adjusted for the delay in seeking care at the time of that gap, but I was wondering if there was a difference between the exposed or the HIV positive kids and the HIV negative kids, even if they're exposed or not. Basically trying to understand like health behavior and how the mothers are behaving when there's a child with symptoms. And did you?
Yeah, that's a great question. So we looked at that really from 2 different angles. The first is the variable that we adjusted for, which is proximity to healthcare services. Essentially what that's asking is from the moment that you decided your child needed medical care, how long did it take you until your first contact with the healthcare system? And we expected there to actually be quite a bit of variability there. The truth is, Botswana's network of clinics within Gaborone is so extensive, you're never really more than 5 to 10 minutes walk from any clinic. So the truth is about 90% of the children were seen at a clinic within the first hour of when their caregivers thought they needed to be seen. So we haven't seen a lot of variability within those groups.
And did you check like the number of days with symptoms before seeking care?
Yep, so we looked at days of cough and days of fever, and then also just general measures of disease severity on presentation. We didn't see any differences in the exposed, uninfected, and unexposed group. The infected children, as you might expect, showed some signs that they had been sicker for longer and presented with more severe disease.
Thank you.
Matt, I had a question about whether you looked at the mothers at all, and what number were new infections, or if you were able to find out that, versus what number were mothers who had been infected longer potentially, even if they were on ARVs. Are you able to kind of look
Yeah.
at that at all?
I haven't looked at those data. We do have data on just crudely when women first tested positive. So was it before pregnancy? Was it during pregnancy? Was it at the time of delivery? The other key pieces of data that we have for many of the women are their CD4 cell counts throughout the pregnancy. And what antiretroviral therapy they were on during pregnancy. And we have started to look at those data as far as, is it that the children that do worse are the children who are born to moms with advanced immunosuppression? Or, there are some concerns even that being exposed to combination antiretroviral therapy could lead to immunosuppression to the degree that it could affect your pneumonia outcomes. But we haven't fully gone back and really looked at those data.
Since you're doing your testing at a referral hospital, my assumption would be that the mothers didn't, for the most part, give birth in that hospital. So how hard is it to be going back and track down those records for the mothers?
Yeah, so actually Botswana has all of the children have what's called an under 5 card. You're given it when you're born, and all of the details of the mother's relevant health are included in that card. And it's pretty amazing. We literally have maybe 2 or 3 children in the entire study who did not actually have that card available when they presented with pneumonia. The caregivers are extremely good at always bringing it with them when they go to seek medical care for the child. Vaccines are recorded in there. So it's really a great document that we get data from. We do then, there is an electronic medical record system where actually all of the HIV testing, things like ELISA, all of that is entered centrally into the electronic medical record system. So we do, whenever possible, go back and verify testing, but certainly a lot of the tests are done by rapid and are just recorded in the child's under 5 card. In some ways, it's much easier to figure that out than it would be if you were to do that study here. So.
Yes.